Hi, everyone. Charlie Piamarini, Stephanie Ochoa, physician associates back here with MedCanna Today. We have another guest, Dr. Rachel Ceasar. She is a medical anthropologist and assistant professor in the Department of Population and Public Health Sciences at USC's Medical School. Currently, she leads the USC's Maternal Cannabis Lab, where her and her team document historic and systemic inequities people face when they use cannabis during pregnancy. Their goal in this work is to research and partner with maternal health providers, patients, and cannabis dispensaries to develop person-centered, harm reduction-based education that supports rather than criminalizes parents during pregnancy and postpartum. This is a topic near and dear to Stephanie's heart, and I think it's a topic that doesn't get a lot of attention. So this is going to be a really interesting topic, and I'll let Dr. Ceasar kind of talk about your background, talk about what brought you into the public health realm coming from medical anthropology, and what interested you in this really cool topic.
Yeah, I've always been interested in cannabis research. I had a mentor at UCSF, Dr. Kelly Knight, and she was doing work on, we did an ethnography. So we did like using methodology where we would be in person, talk with patients who were using opioids and had chronic non-cancer pain, and also had a history of substance use, and just trying to understand how they were managing pain with their providers. So we'd interview providers, interview their patients, and then interview and kind of do an observation of what that negotiation interaction was like around pain management. And cannabis at the time was not legal. But there were a lot of policies against no longer giving opioids to people because they essentially were getting dependent on them. And cannabis was always kind of this thing on the side. And providers they're like, as long as you're not using cocaine or like other heavy, I'm putting in quotes here, other heavy kind of substances or alcohol. And so I was always kind of curious about cannabis. Like providers didn't really have a lot of knowledge about it. Patients were using it kind of what felt like more medically or recreationally. And so I was always kind of interested in that and like following kind of taboo subjects. Like, there's a lot of blanket statements. I feel like cannabis is amazing and a miracle drug, or the other side, cannabis is awful and a gateway drug. And when we start looking at people's stories or looking at people who, have severe pain, chronic pain, or in the other study after that one where I do work with Dr. Ricky Bluethenthal on looking at mostly marginally housed folks, but here in Los Angeles and Denver people who inject drugs. And obviously cannabis is not going to replace heroin or fentanyl, but for this population who's really suffering, what does cannabis look like in their lives? It's not going to replace heroin and fentanyl, but in that study, we're seeing, at least lets them kind of get through their day, between using fentanyl in the morning and then the next time they need to use fentanyl or heroin, cannabis maybe can kind of let them get through that morning period after that first hit.
Right. That's fascinating. I think you touch on a subject that's near and dear to our hearts, and that's the lack of knowledge in medical professionals around cannabis. And like Stephanie, I always say, it's the right drug for the right patient at the right time. And I think cannabis should serve, some type of purpose for some type of patient. But like you said, a lot of people are cannabis is a miracle and it's going to cure a lot of things. It may. We don't have research yet to substantiate those claims, but there are some bad things, with cannabis and everything, especially with mental health and bipolar and schizophrenia. Our last guest was talking about, not even recommending cannabis for people under 25, because of prefrontal cortex formation and stuff like that. So yeah, I think it's really important work that you're doing. You're really just putting a spotlight on the lack of knowledge and on the lack of, the disparities that are around cannabis typically are around disparaged communities, right? African Americans, inner city, Hispanics, and so like they really aren't even getting medical care anyway too. And now they're having cannabis use and they're really all even more pushed to the side because people are like, we don't want to deal with this. And so I think you're doing really important work, and I think that's great. So you
Actually, to comment on that, that's why I wanted to bring you on the show, because that's what brought me and Charlie together. The fact that we agreed that if this is going to be a medication or if there's going to be medicinal programs, then all providers that see any type of patient should have the basic knowledge of what cannabis is, where it comes from, who should use it, and who shouldn't use it. Because let's say you see a patient and you see a medication that's contraindicated, I mean, you should at least warn them to go see someone that can review that list. Like, hey, I don't think that you should be using cannabis because of this medication, because there could be an interaction. You know, you can spark up a little light into the patient's head so that then they can go and see someone who is certified or knowledgeable enough on the subject. So yes, thank you for your work. We really appreciate it, and we need more clinicians and researchers like you. And that's why we were talking about descheduling, right? Because if they deschedule, then we can have more of this research that we need.
Yep, that's a great point. You know, kind of what we talked about last time, Dr. Ceasar, is I brought up the point, you know, not every provider is prescribing opioids, right? But they still understand what an opioid does and what it is and what the contraindications and drug-drug interactions are. So why, you know, cannabis is still being used pretty widely at this point. State of Arizona, where I live, it's both rec and adult use and, you know, medicinal. So you can walk in and get it. So how many of these patients are actually using it? Not even telling their provider. You know, I got patients on a day-to-day basis, you know, give me the lean in whisper, hey, you know, I just want to let you know, don't tell anyone, but I'm using cannabis. It really helps. I'm like, I'm not going to tell anyone. And that's great. Right. You know, and so, you know, I think you're just really putting a spotlight on something that a lot of people aren't thinking about. And I think that's amazing. So you kind of sent us over your latest work that you're working on in your lab. It's titled Safety versus Separation, Person-Centered Experiences of Using Cannabis During Pregnancy in California. So can you kind of tell us a little bit about what your study is and kind of what you're looking at and, you know, why this is so important?
Yeah. You all can call me Rachel. That's okay.
Yeah.
Yeah. And like, you know, I'll say up front, like, I'm not a scientist who like looks at the plant itself and like, you know, can test whether it's safe or not in the body. So I'll say that up front. But a lot of the work we do is qualitative, where we do interviews or focus groups and just trying to understand some of the knowledge gaps around cannabis use during pregnancy. And so this is just kind of the glimpse. We're still in data collection, talking to providers as well as people who use cannabis during pregnancy. But what we're learning from providers is, you know, they're really just kind of relying, you know, out of the goodness of their hearts of kind of self-educating themselves,
right.
You know, looking up articles if they have the time, or, you know, understanding kind of what the different medical associations, their stance on cannabis, which basically all of them are saying, like, you know, cannabis, we don't know enough about cannabis right now. During prenatal or postpartum or during nursing. So we need to make the recommendation that, you know, tell your patients don't use cannabis.
Right.
But between don't use cannabis and, hey, I'm using cannabis, or can I use cannabis, there's just not a lot providers are able to provide. And I think that's where a lot of like miscommunication can happen. So we're learning, you know, they're self-educating. They're essentially taking each patient case by case because there's not really a guidelines there. So that introduces what we believe can be a lot of bias. If you're just, you know, there's some good things of individually treating a patient as the individual, and hearing that story in their patient journey, but that also can be quite problematic as well and can introduce bias, which we saw a lot in our opioid study as well. And the third thing we're trying to see as well, that we're hearing too, and kind of what you were talking a little bit about earlier, Charlie, that, you know, because people are afraid to disclose and providers are aware of this, they'll kind of avoid the discussion as well. They won't kind of go in that direction with their patients because they're aware of a lot of the inequities, you know, in the medical system as well. And they're afraid, like, if I bring up cannabis, I'm also bringing up this criminal, you know, the ties to the medical system,
Right.
with Department of Child and Family Services. So like, I don't want to break that bond with my patient. I want to keep them engaged in prenatal care. So even providers we're finding are kind of scared to talk about it with their patients.
Interesting.
That is true, and I can attest to that. The times that I would be forced to say something is if the drug screen would come back positive, simply because of documentation. I have to document that we had a conversation and that I was, recommending the pregnant patient to not use it because there's not enough research. But did they stop? I don't know, and I would tell them all the time, hey, we don't, I personally, as a provider, don't have a strong stance in regards to it's good or it's bad because of the lack of research. So we're just not recommending it because we don't have the proof that it's okay for you to use it. But if you've been using it your whole life and this is pregnancy number 5 and you smoked or you used cannabis your 4 other pregnancies, I mean, who am I to tell you to not use it, right? But all I could do is document the right things so that later on I don't get in trouble.
Exactly.
And I was a little careful as to what we would talk about, because sometimes they would, like a social worker would go talk to them when they're at the hospital, depending on what was written on our prenatal notes. So yeah, you are right. We do have to be careful, and I don't know. We look out for the patients too. We don't want them to get in trouble.
But I think that plays into modern day medicine being defensive medicine, right? When we practice medicine, it's all about, the litigious society. You say, okay, what can I get sued for on this? And how do I mitigate any type of lawsuit potentially? So, if I'm recommending cannabis or CBD, I've got to put a litany of things about, all the lack of research, potential this and that. But we're kind of behind the 8 ball on that, but that's kind of what we're working on, right? Is educating similar to you, right? You're looking at the study of the lack of education for providers along with their bias. And we're working on trying to educate the providers to decrease any bias or preconceived notions. And so, Rachel, and kind of some of what you're looking at, what are some of the barriers that you see to these medical professionals and why they don't know anything about cannabis? Do you think it's just naivete? Do you think it's just because of the stigma? Do you think they just really didn't care? Or, what are you seeing?
Yeah, I think some of it, and Stephanie, you kind of pointed to this, like your hands are kind of tied. Like there's basically one statement you're allowed to give, and there's not enough research and you shouldn't be using cannabis. But then the reality is that a lot of people are using cannabis and they're looking to their provider for that kind of support or research, or, as a confidant in many regards. Prenatal brings people into prenatal care, can really bring patients who maybe don't engage with the medical system as often, brings them in there. And this is kind of their opportunity, the medical system's opportunity to be like, hey, come on in. Like, it's a great opportunity, I think, for medical systems. It's kind of one of the only times you're going to engage in a hospital or a clinic where there's a positive outcome. You're having a baby,
right?
So it's exciting. It's a time I feel like clinics and hospitals could really do a little bit. This is just my personal, not research, but personally, I feel like that it's a missed opportunity. Like prenatal can be a very special time clinic-wise. Research shows that a lot of times people who are engaged in substances, like they might stop using during the pregnancy period. So there's just a kind of a lot of missed opportunities to talk about substance use. And, I just feel like providers have their hands tied, but, we're heard, I think, because a lot of the providers do care, that they don't want to talk about it. They want, like Stephanie, exactly what you're saying. We heard from providers too. Like, I want to keep it safe for my patients. Like someone's calling child services, and there's been such kind of a increase in calling child services across the U.S. Provider reports of infants to child welfare has increased over 400% in the last decade. So that kind of health provider to child service pipeline is real and scary. And we're hearing that also from, patients, from the people who use cannabis during pregnancy. And, I'm here in California, I'm here in Los Angeles where our research takes place. And, there is definitely, socially very accepted cannabis, and people are open to it, and they hear people who use cannabis. It's very all over the place on the billboards around here. But even here in California, where it's legal, for pregnant folks, not only are they threatened with punitive action, like actual, calling of child services, separation of the infant after birth because of cannabis in the urine, or someone's husband smelled like cannabis and they were removed from the birth.
Wow.
That's my biggest fear, having my patient come back to, in their 6 weeks postpartum visit and tell me that they took their child away because they found THC in their urine. Like that would break me.
Right. Yeah. I mean, it's interesting. We allow, there's other medications that we allow in pregnancy, like opioids and stuff like that we know have, just such negative effects on the developing fetus. And, to the fetus coming out with withdrawals and stuff like that. But we don't report people like that or taking those medications to CPS or Child Protective Services because it's a prescription, right? And so cannabis still is kind of this wild west of, it's almost like this elephant in the room where the federal government owns multiple patents. The NIH owns multiple patents on CBD and cannabis and its benefits, right? And medicinal benefits, but yet they're still keeping it as a Schedule I narcotic, kind of just sitting back and waiting to see kind of what's going on. Because they're just waiting to see how they can monetize this, honestly, right? Think about it. That's what they do. And I think once it becomes descheduled, or even if they move it to a different class that we can write prescriptions for it, I think you're going to see such a stigma hopefully be removed. There's still going to be people that don't want to write it or, don't want to go talk to the doctor about it, but hopefully it opens up. It sounds like, these pregnancies become almost like a funnel for the medical system where, like you said, I didn't even think about that as a great point, that a pregnant woman may never go to the doctor until they're pregnant. And then they come in and then the first interaction they have with some stuffy person wearing a white lab coat and a stethoscope and says, you can't use cannabis. If you do, I'm going to call, CPS and take away your kid. And they're like, wait, what? I came in here for help. Now I'm not coming back again. Screw you,
Mm-hmm.
So I think that's really interesting and sad and very, very sad.
Yeah. I was reading one of our this interviewer is still in data collection. So I was reading one of our newer interviews, and they just said, like the provider, they're just doing weight and ultrasounds, and the social worker, I don't even want to let them know that I'm stressed or that I need help because I don't want to look, messy. I don't want to have anything like there's anything wrong or any reason to take my child. And, I'm forgetting what CAPTA stands for now, but what is this called? But basically kind of CAPTA, the Child Abuse Prevention Treatment Act, it says, you cannot just have a positive test for any substance. Like you need to show you have to also show a clear health impact as well. You cannot just, these reports should not be taken by child services just for a positive urine. But, we've been talking to providers. My team was just telling me today about a new interview that the provider said it can be for anything. Someone smelled like cannabis, in the clinic, this patient smelled like cannabis, and you can make a call. Those calls are kept.
Yeah, this creates a lot of disparity in medical care. Like I've got people that are ex-cops telling me they take cannabis, right? And how much it benefits them. And now you're trying to take someone's unborn child or, full-term baby away from them because they smoked cannabis or smell like cannabis, right? But if they used opioids or fentanyl, it's okay, basically, because it was a prescription, which is just fascinating.
They'll refer them to psych or to a clinic, and then they'll see someone, get help, and go home. But it's not the same thing for cannabis.
So, Rachel, how do you guys recruit your patients and your providers? Is it kind of just you guys are cold calling, reaching out, or do you guys put out, billboards or emails, or kind of, what's your process?
Yeah, for the providers, for the first study, we kind of did locally, like reach out to one provider. It's called like a snowball effect. And then they kind of reach out, hey, can you recommend someone? So that's what we did for our first study. The second one, we really said, let's be more strategic, especially when we wanted to get views outside of Southern California. And so that's how I found Stephanie, was like reaching out to every professional society who does work
interesting. Okay.
in maternal health. And so that's how we recruited providers. And we're still recruiting. They're hard to get. Providers are hard to get. So definitely still recruiting. In terms of people who use cannabis, we end up going on Facebook and putting an ad on Facebook. And people were telling me that was a good way to go. I think Instagram, you needed, like, if you're collecting lots and lots, like hundreds and hundreds of people for a survey, but because these are one-on-one interviews and we wanted people to be able to, anonymously in many ways be able to, contact us through Facebook. So we thought that was a good way to kind of get a broad range of people across California.
Interesting. Okay. That's
maybe we could post your flyer, the flyer that you emailed me, on our Instagram.
That'd be
maybe great. There's any providers that can reach out.
Yeah, send it to us and I'll put it in your bio. We have a link in the website where I put up a picture of you and your bio, and I can put up your flyer in there too. So just email it to me, to us, and I'll put it up on your website when we post your stuff. So that'll be cool, just to try and, hey man, anything to get education out there about proper use of cannabis is kind of what we say. But you're doing some really great work, and I think it's really important, and it's probably, so underfunded. Like we were talking before about, you're trying to get funding for these type of things, and funding is so far and few between, especially for social kind of sciences like this. People don't want to fund it, right? They want to fund the sexy cancer research or the drug research, or they forget about some of these things. And so, how do you guys have any, do you take donations, or do you guys take any other, how, besides just the funding that you get that's internal or even external from NIH, how else do you guys keep afloat?
Yeah, a lot of our pilot grants have been internal, so through the University of Southern California, and our kind of next steps are looking at foundation grants. I know a lot of colleagues who have done really well, clinicians mostly, and so we're looking at March of Dimes, who I've been in kind of communications with, and just when are you going to fund cannabis research? So just kind of been talking to them, and really kind of in the last year, they're like, okay, we are, because it's federal, there's some federal restrictions, and they're like, okay, we're starting to fund it, and so that's really exciting to try a foundation. Also in California, from the taxes from tobacco, we have, let's see, I always forget what it stands for, but there's a tobacco-related disease research program that's funded by some of those taxes. And so that's another thing I'm really interested in. And I don't know if you've all seen in your work as PAs, but I'm wondering if some of the folks who are using cannabis, what's the story before they use cannabis? Is there, transitioning from tobacco? Is there transitioning from vaping? Is the cannabis the harm reduction for using the tobacco? And trying to kind of understand some of those transitions as well.
Right. Yeah, I think
I haven't really asked my patients. For me, it's a quick question, do you smoke cigarettes? How many a day? For how long? And then as far as cannabis use, do you use it? Yes or no? And then we kind of move on to the next question. So I don't really know what their story is. I do know in regards to vaping, most patients that are trying to quit smoking do turn to vaping. But I'm not quite sure if it's just CBD or THC vaping or nicotine vaping. I haven't really gotten into those details. How about you, Charlie?
Most of my experience is pain management and family practice. So a lot of times the pain management patients were using it as a last ditch effort because they were so tired of being in pain. And, I always tell my patients cannabis is such a personal journey that they are actually able to kind of really take the titration and, the medicine back into their hands. Instead of me writing a script for them to go to the pharmacy to pick up Percocet, they're able to go to the dispensary and really kind of experiment with different strains and different percentages and ratios. And so I think a lot of them just came to it because they were just so tired of the typical medical system and the pills and stuff. They're like, I want to try something natural. And lo and behold, a lot of them had great results. And so I think that's what a lot of my my patients came to their cannabis journey, but I could definitely see a lot of patients using it as a harm reduction, right? Like, hey, I used to do other drugs and I'm using cannabis to alter my reality. And all right, I'd rather you do that than shoot up heroin on a daily basis, right? And so, it's a good alternative to that. But yeah, I think what you're doing is amazing. I've said it, and I'll keep saying that because I think that's great work, and I think what you're doing is super important to our field and to medicine in general. And however we can help you get your message out, let us know. Send us your flyer, please. Send us any social media tags or anything. I have multiple accounts, so we can share it across. To try and get it out. I think it's super important and super cool. And if there's anything Steph and I could do to help you, consult or help with the study design, or hey, how do I get these stupid providers? How do I wrangle them in? Because we are a fickle folk, and we're the MAs always throw stuff on our desk, and they're like, "I threw this on your desk 5 days ago to sign. Can you please sign this?" And you're, "Oh yeah, I forgot." Right. And so maybe we can help you out and get in their ear a little bit quicker.
So you're looking for awesome clinicians only in like women's health, or any clinician?
We definitely opened it up because we were getting feedback, from someone, someone who's a clinician who was a provider working in the ER. And,
wow.
I was so embarrassed. I was like, of course, not everyone is engaged who's, pregnant is going to be engaging in prenatal care. Like maybe ER is their first point of care for prenatal health.
Yeah.
And so we started opening it up a little bit more, or family medicine. So we've definitely kind of anyone who is, you have to be in California because we've limited the study just to California, but anyone who is, provides care to people who use cannabis during pregnancy and, can be able to have a conversation around that. So we've talked to, dietitians, doulas, we're definitely kind of interested in midwives,
oh, wow.
PAs, kind of interested in the broad gamut, just to kind of understand what the different points of care, where people are coming from, what maybe they have different ideas. I mean, one thing we've heard from some providers, like maybe, and just kind of reflecting what you shared earlier, Stephanie, is there some kind of third space where like you're not under the medical system and you can still get some care or questions answered about cannabis, and it's separate from the medical system. It's maybe with other patients who are also using cannabis during pregnancy or have questions about substance use. Just kind of like a safe space or a group space where you can get those resources, and it's not going to go to social workers or child services. It's just kind of a safe space. And one of the providers kind of mentioned something like that.
That's it. That's super interesting. Kind of like this, like almost like a dead end where the information stops and it's not going to be reported to anybody. That's a really cool idea. Like, this is a safe space. You can talk about the cannabis use all that you want, and we're not going to tell anybody. Super cool. Yeah. Let us know if you need help.
Maybe those spaces exist, but I don't know.
Yeah. Let us know if you need help.
I don't know either, but we'll stay in touch and hopefully we can make something happen.
I wonder if it's almost like a, just thinking here off the top of my head, like they've got like the nicotine hotline, right? You could do like a cannabis hotline where, it's a legitimate, funded by the government or by USC or whoever wants to fund it. And we hire, cannabis nurses and PAs and doctors to give a safe space to people to call in and be like, hey, how do I approach my doctor? Or, hey, what do I do with this? I don't know, like it's borderline, giving medical advice, but I think that'd be something cool.
Yeah, I gave a talk last week to the City of Berkeley Public Health Division, and I presented my slides and about our research. But most of what people wanted to know were these questions, and these are all providers, community health workers, lactation consultants. It was like over 100 people, and just like, well, so is CBD safe? And, right. I'm just kind of like, well, this isn't my research, but let's, I have some slides where I've looked it up already. Like, right. They just needed to know the answers for their patients.
Right.
And so I was like, I could probably put an infographic together, or just let me do the research, which is my job, and kind of like, put this together, or have a regular Q&A or something,
right.
where I can do that, because people just question after question. And, it was really, a lot of them I didn't know the answer to either. And I was like, well, let's look it up. Let's look it up together. What does the research say? What do these medical societies say?
I think that's great that they're that excited, right? Now that's like, it's almost kind of like it was so taboo, and now it's kind of coming into like, you have a PhD in your, on faculty at USC Medical School, and you're coming to do a presentation about maternal cannabis use, and like, okay, maybe it is safe to talk about this. And, and so you're able to really kind of tease people out where they're able to feel comfortable in asking a question instead of like feeling, so ostracized and looked down upon. But yeah, Steph and I are available if you need help to help further the mission, man. So if you need us to help out, ask us. We can always help prepare slides for you or help give you some content. And, Steph's on the board for the PA Society for OB. And so she can help you out with that. And so, yeah, we'd love to collaborate. And, I really appreciate you coming on. And Steph, any final questions?
No, I think I'm good. Thank you for coming on the show, and I'm really looking forward to working with you. We're actually hopefully going to work on a policy paper on maternal cannabis use for the PA organization. And yeah, I appreciate your time.
Wow, that's great. We appreciate you coming on. Thank you everybody for listening. Rachel, if people...
Yeah, I'm at LinkedIn, Rachel, Rachel, Ceasar, Ceasar. I'll definitely share kind of our maternal cannabis labs website,
you're good.
And our Twitter.
I'll put it in the show notes. I'll put on, we have the YouTube, we put on YouTube, I'll put it on Spotify, I'll put it on the website. So we'll put it in a lot of different places for you to really promote it. But again, we really appreciate what you're doing, and fighting the good fight. So with that, everyone, thank you for listening. MedCannaToday.com if you want to read any of our blogs or watch any of our videos. And with that, everyone have a good evening.
Thank you.
Well, thank you so much.